Hello everyone, my name is Corinthians and today I'll be doing an overview over a nutritional intervention regarding anorexia nervosa. Okay, so firstly I want to kind of go over anorexia. It's an eating disorder in which an individual will severely avoid or restrict food due to like a distorted image of their own body or just because they have a fear of gaining weight. And this typically coincides with bulimia because individuals with anorexia tend to have um, tendencies of like episodes of purging or binge eating that would have them resort to purging. So I want to get into the problems of anorexia nervosa. So firstly, anorexia can result into dangerous health conditions just because of malnutrition, and individuals who normally avoid eating foods or restrict themselves from eating tons of food, they do not meet the standards of nutritional requirements set by the RDA, and this can result in conditions like thinning of the bones, like osteoporosis, osteopenia, because they're not getting the right amounts of calcium or phosphorus, or mild anemia for not getting the right amounts of iron, muscle wasting, fatigue, delayed puberty, mostly seen in adolescents who have anorexia, infertility, low blood pressure that can cause a very light pulse and slow breathing, or organ failure and even death in the worst cases. So I want to kind of mention that in this literature, the studies stated that the most effective way to restore weight is in inpatient care and with constant nursing, constant staff, and very supportive psychotherapeutic sessions. However, there hasn't really been any pharmacology or pharmotechnology or sorry, pharmotherapy. That's the word. So individuals with anorexia, they tend to have a lot of depression that they deal with, and that it intensifies their desire to want to restrict food. So in this particular study, it was just assigned to see if there was selective serotonin reuptake inhibitor would improve restoration outcomes and reduce relapses in anorexia patients. So the primary purpose of this study is to just assess whether fluoxetine improves the outcome and prevent relapse in comparison to a placebo after 1 year of discharge from the hospital. And there's a secondary aim to see whether fluoxetine produced a reduction in depression, anxiety, or OCD that assisted in the eating disorder behavior. So let's get into the methods. So there were 39 women originally. Well, really it was like 95 women. They got narrowed down to 39 women with anorexia. Then that got further narrowed down to 35 subjects. So the 35 subjects were split into two groups based on their average body weight, greater than 90% average body weight or less than 89 average body weight. And this was a double blind placebo trial, meaning that the researchers nor the subjects knew which which drug or placebo they were getting administered. And overall, the subjects were assigned 16 to the fluoxetine or 19 to the placebo. So furthering the materials and methods. So the subjects were started on fluoxetine 2 to 4 weeks before leaving the inpatient facility or the hospital, and each of them began with one capsule of 20 milligrams fluoxetine or a placebo a day. And after discharge from the hospital, subjects were evaluated in person for 4 weeks intervals for 52 weeks or a year's course. And then these evaluations were conducted by licensed physicians who were blind as well to the patient's medical status. And I just want to mention that depending on their evaluations, physicians were either they were able to kind of increase their dosage or decrease them just depending on the patient. So the results. So there were 16 fluoxetine treatment patients, however you want to put it, but there were 10 individuals who completed the 52-week course and 6 people who dropped out. And um, 2 physician recommended the dropouts, and then 4 individuals or spousal dropouts because um, the patients were given an option if they felt like they were about to relapse or they felt threatened relapse, they were able to drop out, and they were able to do that if they felt like their health was at risk. And the three placebo completers and 16 dropouts, and five physician recommended out of the 16 to drop out, um, just because they felt like they were at risk for once again relapsing, and then individuals or spousal dropouts. I just want to mention, like, emphasize how spouses were really able to be participants in this study, just to kind of care for their spouse and loved ones overall, just being supportive. So I want to get into this large chart. I know it seems very overwhelming, but I want to kind of like point out the main things just for time's sake. So the average body weight in the beginning for the fluoxetine treatment completers, it was at 88, and then we see there's an increase there um, with the completers and some increase here, but we see that with the drug, there's not really a significant difference between the placebo or the fluoxetine treatment completers. But we can note that there's some weight gain here. Opposed to the dropouts, we see like some negative here, just highlighting the fact that they probably relapsed, or there's just some sign of like no significant weight gain. And then the HDRS, I'll get into that more on the next slide. We see some significant difference between the statuses. So, and this is also like a depression rating scale. Once again, I'll kind of get into that on the next slide. But we see some significant difference here with status comparing the fluoxetine treatment and the placebo treatment. Getting into these tests right here, they were about the obsessive scale. This is the obsessive scale test. Oh, where is it? And then this is the eating disorder scale. And it just shows like from the beginning, the start, versus the change instead of like the end. It's more of like the change. I'll get into it on the next slide. So, as previously stated, there was a difference in average body weight. The fluoxetine treatment completers saw a significant weight gain, 5.3% change compared to the dropouts, as mentioned. The placebos also saw some change, but it was just less consistent. And as we've seen with the p-value, there was no significant change or difference between the dropouts or the completers as far as weight gain. This could just highlight some good weight restoration, and that can be subjective to an individual. And then we have the Hamilton Depression rating scale. Fluoxetine completers showed a notable reduction in depression scores with negative 8.2 compared to the placebo group, which had a slight increase, 1.7. The Hamilton Anxiety Rating Scale, fluoxetine completers saw a moderate reduction in anxiety, whereas the placebo group saw smaller changes. Just to highlight, individuals who took the fluoxetine had a much higher reduction in anxiety. And then finally, the Yales-Brown Obsessive Compulsive Scale. There's significant improvements we're seeing in the fluoxetine completers compared to the worsening or smaller improvements in placebo groups. So the discussion. So a third dropped out while on the fluoxetine, and studies show that this can be due to malnutrition, because it's possible that lack of essential nutrients can neutralize therapeutic actions of SSRI, meaning if individuals are not getting enough nutrients, it can counteract the use of antidepressants or SSRIs. I just want to note that hold on, I'll be right back. Excuse me. So tryptophan, okay, it's an essential amino acid. We kind of discussed this in lecture, but it's an amino acid obtained by eating, of course, essential, and it's the precursor for serotonin. So it's significantly lower in healthier women who are dieting. So you just imagine individuals with anorexia, they might have a more significant lower level or levels of tryptophan. I believe. Yeah. So that can just kind of go into play where we don't see as much um, an improvement of the eating disorder, or as far as mental status, we don't really see any improvement there because it is assumed that individuals who take this drug are nutritious, and the depletion of tryptophan reverses the effect of antidepressants. So the possibility that fluoxetine is effective for um, anorexia is just supported that there's some change in serotonin levels. So that's associated with weight gain. So individuals who are having the right amount of tryptophan in their diets or receiving that amino acid, we can kind of say that they are at um, a healthy weight. And then we have limitations that include very small sample size due to the refusal or possible relapse, so that, included individuals dropping out of the study. And then we just had a large geographical region. A lot of the patients were kind of scattered around the US, and that was hard to find, different physicians or different psychotherapy support for them. And that can lead to um, just inconsistency with the follow-ups. And then just to kind of further the study better in the future, refusal in this experiment just leaves room for other possible SSRI medications in the future, maybe to access different pharmacological treatment for anorexia nervosa, because there are many different types of antidepressants that can possibly help the restoration of weight gain and just reduce the amount of individuals who are more likely to relapse. Okay, so overall, this study does support the possibility that pharmaceutical therapy is effective in improving the recovery of anorexia, because 63% of the subjects completed a 1 year trial of fluoxetine. So we can just say a lot of people really stayed in the game. 16% of subjects completed 1 year trial on placebo, but the dropout rates were lower for fluoxetine. So this just suggests that there is a potential benefit in long-term treatment, just because individuals were more consistent when they were on the antidepressant. Overall, based on the results, fluoxetine completers showed significantly better outcomes in weight gain and symptom reductions, especially for depression, anxiety, and OCD symptoms. And once again, this just gives us hope for more pharmaceutical or pharmacological therapy um, coinciding with anorexia. All right, thank you guys for listening.